Okay, admittance form is the paper that we get, or any form that we get when a patient comes into the clinic. So ours is called the check-in form. It's pretty much the same thing. We're admitting this patient to the hospital. His name is Roscoe. We know that he is a 6-month-old domestic short hair. He's a male. We know his birthday. Our check-in show the owner's name and information. This one, because we've seen the kitty before, it lets us know, just from the paper what vaccines it might need coming up, or if it needs anything, or if it doesn't need anything. We're also able to put on our forms if he had any kind of allergic reaction to, like maybe his vaccine or something, just to call it out to our attention. So this particular kitty we seen a week ago, so we do know a medical history that he was sick with upper respiratory viruses, and so now that he has gotten over that, he is here to be neutered. So then, along with his check-in form, we have his medical history that stays into the computer. So if this kitty was to ever go anywhere else, to go Texas A&M or somewhere to get other diagnostic stuff done that we might not can do here, all of his stuff would go into his patient files. So this is anything that we've ever done to this kitty. This is what we know about him. And like I said, if there was ever any x-rays or ultrasounds or anything else done that we are not able to do in this clinic, we would come back and we would plug it into his patient medical history. So from there is the consent form that we had the owner. We went over what we're doing with our patient today. We know that Mr. Roscoe is here to be neutered, so she knows that the cat is going on anesthesia, that he is having the surgery of being neutered. We are giving him post-op pain medicine and a night of hospitalization, which he'll be staying here with us. So our consent form, she consented to let us do these particular things on her kitty. Okay, so identify the kitty that was going to have surgery with anything that may have come with them. Here we label our cages. This is kind of our cage cards. So we know that cage 1 has its own basket over here. Here's basket 1 that goes with cage 1. Anything that comes with him, his check-in paper, what he's here for, everything goes into the basket of the cage that he goes into. And when he's also put into that cage, he gets identified with the collar. Every patient has a red collar, and the collar states what they're here for, what their name is, and that's how we verify. So when we're taking this kitty out, we're looking at his collar, we're matching it up with his paper to make sure that we have the correct animal that we're going to be doing the correct procedure on. So that's identification and cage cards. Okay, the laboratory forms, a lot of ours get stored into the system. We get to run some in-house blood work here, so our CBC, our blood chemistries, all the information from our blood machine just goes straight into the patient file. This particular patient, we kind of check her blood work on a yearly basis. So a good thing about our laboratory forms is that we can pull up her blood work, and then we can compare it to things that were done the year before, things that were done, like 2 months before. So we can compare how her levels are doing from that point to this point. Other things that would be under laboratory forms are things we may have sent to the lab, urinalysis. The results from that would go into her medical file, along with, like for us, we have done x-rays on this dog. So her images are also a lab result that would be in her medical file. That is my x-ray. We have done x-rays on her, and they go into her, there we go, there's her images. So these are just all lab forms that we do in our clinic here, and it just all shows just results for that particular patient. Our patient, Roscoe, also his owner had to sign an anesthesia consent form. It is just our way of kind of going over the procedure of what the kitty will be doing today. It gives her the option whether she wants to do pre-anesthetic blood work, which we always recommend, and that's what we talk to her about, or any of our patients, over why we do them, what we find if we find something bad, and so it's totally up to them after they know their choices whether they want to do it or not. So she opted not to have anything done on him, and she signed her name saying that I don't want this and I don't want this, and she still understands the risk of her kitty going down. So this paper also gives us a chance to make some quick notes while surgery is going on, and then we can plug it all into his medical history when everything is done. Okay, so discharge instructions. We just discharged our cat that we did the neuter on yesterday, Roscoe. So this is just a copy of the receipt, and we like to put instructions on there that the owner can read. It's in the blue when they get home, but we also go over everything with the owner along with it being written there. So, things we want to tell them is that we want to restrict his activity at home if possible for the next 7 days. We want to tell them to keep an eye on his incision site. We don't want to see any discharge or redness or anything out of the ordinary from the way that it looks. Try to keep him from jumping on and off of things. Try to discourage him from licking at it. If that we'd like to know if he's messing with it, then we can get them like an e-collar to put on to keep him from messing with his incision. Possibly anything else. If he quits eating or just starts acting abnormal at home, these are all part of the discharge instructions that we would like to know. Now, this particular cat was given injectable pain medicine here, so none went home with him. But if the owner starts noticing that they think the cat might be in a little bit of pain or discomfort, of course we want her to let us know, so we can dispense something that will go along with the injectable pain medicine that we gave. Not to give anything that she might have at home, because it might mess with what we had given him. So it's pretty much just, you watch your kitty at home, you let us know how he's doing and if there's any problems, and then we work with her from there. Okay, for my 3 positions on drawing blood, I guess I can start with jugular. I'm going to kind of try to hold him still, keep him with the short legs, keep him restrained. You're fine. I'm going to hold his head up, and that way my drawer can do what she needs to do to get the blood from his vein. Okay, for my cephalic vein, I'm going to secure him. I'm going to hold off the vein up here. That gives her, and I can hold the vein in place, and it gives her the chance to draw blood right there. And then for the saphenous vein, which is on the back of the leg, come here. I'm just going to try to restrain him on his side so he's not going to be flailing around and hurting himself. I'm also going to hold his vein off. That gives her the chance to hold onto his leg and draw blood that way. So those are my 3 ways of restraining. To safely remove an animal from inside the cage is your approach. You're watching the animal to see how they're acting, if they're scared, if they're anxious. Mr. Gunn, he is anxious to get out, so I know I need to watch for him to want to jump out of the cage at me, so he doesn't injure himself. So I'm going to slowly open it and get my hand where I can get it on him. I know he's already pushing on me. He wants to come out of the cage. And I'm not going to open the cage and give him too much leverage to get out. And then I'm going to pick him up, securing him in a safe manner. And then the same thing with putting them back into the cage, is that I want to make sure that he is in there securely. I'm not going to give him the chance to come bolting at me. We'll make sure that it got closed securely and he's in there and safe. Applying a muzzle safely to a dog. There's several different ways we can do it. One of these type muzzles, this one's actually too small for him, and the reason I say that is that it doesn't fit properly. He can't really open his mouth too much. I can't really see, you know, like if his tongue or if he's having a hard time breathing. So we wouldn't want to use one that size. So I'm just going to do a gauze muzzle. I make my little loop. I'm going to slip it over his nose. I'm going to going. I'm going to pull it, not too tight though. That way he can still breathe, do what he needs to do. And then I'm going to tie it behind his ears. Where I can easily remove it if I need to. And it's secure in place, that way he can't get it off with his front paws, and then I can do what I need to with him. Okay, to apply an Elizabethan collar, one of the first steps to doing it is making sure, I've already pre-assembled this one because I've measured it to make sure it fits him. There's different sizes for different dogs. The point is that you want it to fit enough to where they can still get to their food and water, but they cannot get to like maybe a sore that they may have, or you know, itching up around their neck. The point of the collar is to keep them from getting to a particular spot. They don't like it too much, the plastic. So this one, if he had a collar small enough, I could have put his collar through here, but he's got a big collar. So I'm going to use my gauze. I'm going to put the collar, it slips on pretty easy, because I've already fit him to this. And then I'm going to take my gauze that I've already put through it, and I'm going to tie it to his collar just to secure it in place. That way he cannot kick it off, scratch it off, any of that stuff. And I'll make it into a easy tie. I know it's no tip. And there. It shows me that he can still get past it. He can still get to his food and water, but he can't get to anything else. Okay, doing a physical exam, just a quick look over of the animal. You know, I'm going to look in his ears, see if I see any problems, inflammation, dirty that would tell me there's ear mites or something. Nothing. He looks good. His eyes, I would make sure that they look about the same. Nothing's bulging, nothing looks abnormal. He does have an abnormal eye. He had an injury to it whenever he was young. So we do know about the injury to his eye. It's not an active injury. I'm going to look at teeth. I'm going to check his mucous membranes. They're pink and healthy. He looks BAR, bright and responsive to me. His overall body, he looks good here. He's not overly too much weight on him. I can still feel his spine. I can see his waist. So to me, he's a good weight. I know that he's a relatively young dog. So then we move on to listening to him. So I'm going to start with getting a heart rate on him. And we do this by counting beats per either 10 seconds, where you multiply by 6, or 15 seconds, you multiply by 4. Okay, I did 10 seconds. It was 21, so I'll multiply that by 6 to get his heart rate. So I'm going to continue on listening to his heart. I'm listening on all areas of his chest. I want to hear all sides of his heart, all the valves. I hear no murmurs, no abnormalities in his heart rate or his heartbeat. Then I'm going to move on to his lungs. Same with the respiratory rate. I'm going to count the amount of breaths he's taken. About 9 breaths in 10 seconds, so I'll multiply that by 6. Then I want to listen to all the quadrants of his lungs for at least a couple of breaths each. I'm just listening for crackles or wheezes or anything out of the ordinary. I would do that the same on the other side. It all sounds clear. I don't hear anything abnormal. And the last thing I would do is take his temperature, make sure we're not running a fever. Which this always takes a minute, but so I mean, right now he looks completely healthy. I would give him an ASA grade of a 1. I think he's at minimal risk to go under anesthesia. And no fever here, so I'm going to give him a grade 1. Okay, doing a physical examination on a kitty. I've already done the dog, the longer examination, so still it's the basic principles. We're just going to look him over from kind of head to toe. I know a little bit of a history of this kitty. I know he's 5 years old. He's relatively young. He did have an injury as a baby, so I have that in my thoughts and my notes. So I know that he has some issues with going to the bathroom. So I'm just going to start my exam. Kind of look in the ears. I'm going to look at his eyes and his nose. Look at mouth and teeth. Look under the tongue. I don't see nothing there. Kind of a time we'll start feeling thyroid, trying to feel some thyroid glands. I don't feel any. There's no physical history on him. They might have any problems with that. Feeling of his abdomen, for him this would be important because I do know that he has problems, so I would like to make sure there's no blockage or anything feeling out of the ordinary. I don't feel nothing. So on outwardly appearance, I don't see anything, and then you move on to listening. Sweet boy Lucky. So it's the same with the dog and the cat. I'm going to listen for murmurs. I'm going to get me a heart rate. And I can kind of do this within a 15-second period. I won't listen for 15 seconds. I don't hear any murmur there, so I'm just going to listen to all the valves of his heart. And then I move on to all the lobes of the lung. So I know that there's several areas on each side I need to listen for. And then I would move on just to getting the temperature, which he's proven to be ready for that. So while I'm waiting on that, just from physical examination and history on him, and knowing that I'm not seeing or hearing anything on the outside, I would give him an ASA grade of probably a 1, maybe a 2, just because of an injury that he has had. But I would give him a 1 and say that, you know, just my basic parameters would tell me that he would be okay to go under anesthesia. Okay, drawing blood on the dog. Here is his cephalic vein. Get him backwards. He's got it occluded. I'm going to hold the vein next to my thumb, kind of keep it in place. Oop, insert the needle, pull back on the hub. There's that. Good boy. That was a good boy. Okay, I'm going to go to my lateral cephalus vein. Okay, for my lateral saphenous vein. Hold still. I see it right there. He's a good boy. He's a good boy. He's a good boy. He's a good boy. There's that blood draw. Good. Okay, for the jugular blood draw, I'm going to hold and occlude my vein. Take my needle. Here we go, Charlie. Okay.
Sweet boy. Sweet boy. That's a sweet boy.
And for him, we're actually doing blood work, so I'm going to pull a full 3 ml syringe worth.
That's a sweet boy.
And there is my jugular. Okay, doing blood draw on a kitten here, or a cat. I'm going to start with my medial saphenous. It is already shaved. I'm going to use an alcohol wipe just to get any little bit of bacteria I can off of the vein there. Going to kind of hold the vein in place with my thumb there. Pull back on the hub. There's my blood draw there. Okay. Then I'm going to move on and I'm going to draw blood from, as soon as that's done bleeding, from my saphenous vein. My cephalic, excuse me. And again, she's occluding the vein, wiping with alcohol. Gonna hold the vein in place, advance the needle, pull back. There's that blood draw. And then last will be my jugular vein. Get her in position here. Okay, drawing blood from the jugular vein. See it? There we go. I hit the vein. Okay, the minimum databases. They're basic tests that can be run here in the clinic, like pre anesthetic type stuff. They're basic, checking for total solids, total proteins, your ALT, your BUNs. These are 4 basic tests that just take a small amount of blood that can be run together, and then if there's something out of whack with one of those tests, it would push us to move on to other diagnostic. Now, us in our clinic, we have our protocol for pre-anesthetic is to run a CBC, to run a blood chemistry. We just kind of want to look at the general stuff. So our total proteins and those basic parameters are in our results already. So if we see something even more out of whack in our basic stuff, then we would want to move on to other testing. So other testing would be like urinalysis if we see something was wrong with their blood glucose, or doing x-rays if we see that maybe liver enzymes or something is out of whack. You hear a heart murmur on them, you might want to look at their heart. Doing a fecal examination, making sure there's no intestinal parasites. Anything that we would outwardly and inwardly see that might push us to move on to further diagnostic stuff, to make sure that patient is in the best health it can be before we would ever put it under anesthesia. So that's kind of the part of the minimum databases, and moving on to our bigger diagnostic stuff. Just it's all for the general wealth of the animal and making sure that everything goes well during anesthesia. So our anesthetic and pre-anesthetic protocol. Okay, so I talked with my preceptor, which is Dr. Zamzo, of one that we use on an animal. So we chose together. We chose a healthy feline, just a young, healthy feline, going under for, either the spay or a neuter, something simple. So our pre-anesthetic is our atropine. It's an anti-chlorogenic. It helps prevent bradycardia and lowers the salivary secretions. So this is our first drug before we would give our anesthetic. Now our anesthetic is a mixture of acepromazine and ketamine. We call it ace-ketamine. The acepromazine is a sedative, and the ketamine is the anesthetic for sedation. And then we would also combine that once they're kind of getting a little sleepy and groggy. We'll put them on isoflurane, a mask, to kind of get them to completely relax. That way we can get a trach tube down easily when they're completely out, and then we're able to move on with our procedure. So for post-op pain medicine, on this kitty we would use Eloxicam, Loxicom is what we call it, for post-op pain relief. So it just all depends on the situation of the animal, of what anesthetic, what pre-anesthetic, and what post-op pain, and when we would give each of these medicines. But that's one protocol we would take for a young, healthy kitty. Okay, the controlled substance log, it's there for a reason. These drugs that we use sometimes are controlled by the DEA, the state. So you have to make a log of who got it and what they got it for. So we actually had to anesthetize one of our own clinic cats today, so I'm going to make this entry. So I'm doing today's date, which is today's date. It says patient, animal name, and address. I'm going to put our clinic, the name of the cat, and then you add to the log why we anesthetized him. And then our address. And the next entry, species of animal, he is a feline. Name of practitioner given the orders, it's Dr. Janet Zamzo. Name of person administering and dispensing, she also did it, so I'm going to put her name down. Then it has the previous amount that was there, which I'll move over, then how much we gave to Lucky, and then I'll subtract that from that amount, and then it's the new balance. So that's the steps for logging a controlled substance. Okay, so our anesthesia machine, it has two types of way to get oxygen. We have an oxygen concentrator that generates its own oxygen from intaking air from the room. So that there's no pressure valve, there's no anything from that point. It simply has its tube that takes us straight to the flow meter. Now it does have a backup tank just in case we lose electricity or something like that happens and we need to use our backup tank. It's our E-tank here, it's a small one. It does have a pressure valve. It tells us how much oxygen is in the tank. And then it has the reduction valve to where we can adjust the amount of pressure that is coming from the tank, then will go to our flow meter. Now, our flow meter here, when using our normal compression concentrator, like I said, there's no adjusting. The flow meter adjusts the pressure itself. So our valve helps us adjust the amount of oxygen that is leaving and is going to our precision vaporizer. Our vaporizer here has our gauge that tells us how much isoflurane, which is what we use, and here's our little place where you fill up the tank or fill up the vaporizer. So once the oxygen is entered into the vaporizer, then the oxygen and put that back together. Oxygen and isoflurane, the gas, comes out together. It comes into the fresh gas inlet. From that point, it goes into the tube. So this is the inhalation tube. It has a shutoff valve that only allows the gas and the oxygen to leave. It goes to the patient, through the tube to the patient, which is either a trach tube at the end of this or a mask. And this mask can be used a couple of different ways. It can be to gas down the patient. It has to be, there's different size masks, of course. It's got to be able to cover its nose and its mouth, and just so that that animal can breathe simply more gas than oxygen, or it can be used to simply give a distressed animal oxygen if it's having trouble. Okay, so from that point, after the animal has breathed in its anesthetic and its oxygen, when it exhales, it comes back on the outside of this tube. Now we know it can't go back into the inhalation, so it goes to its exhalation, which also has a valve that doesn't allow it to come back through. So I have it hooked up. We're on our rebreathing system right now. So after the animal exhales, it comes into the reservoir bag. Then from there, it goes into our, carbon dioxide absorber. So the gas and the oxygen is filtered out through the absorber. Any excess gases automatically go through a gravity. Gravity just takes the gases away. It weighs more than the oxygen, and it goes through a tube down to our scavenger system. We use an FT air. Is that what it's called? Okay, yeah, FT air scavenging system. So this gets rid of the excess gases. Now this is weighed when we first get it. Whenever it gets to 50 grams is whenever we replace this. So you know it needs to be replaced often. The same with our carbon dioxide absorber. Being that we're using isoflurane, it never turns completely the color purple, an indicator that they're depleted. So we go off hours on the machine. So about every 120 hours of anesthetic use is when we, 12 hours, excuse me. I read it wrong. 12 hours is when we replace our crystals here. Now, going into a non-rebreathing system, I'm just going to change up the machine a little bit to show how this one works. All this stuff goes away, it's not needed. On the non-rebreathing system, we use a Jackson Reese tubing system. So now from our vaporizer, our gas and oxygen goes straight to the patient, and it's usually a very small patient. That's the point of using the non-rebreathing. They don't have enough air to pass it all the way back through the breathing system. So we get to use this little one because they're constantly getting fresh gas and fresh oxygen. So we want them to get rid of it as quickly as they're taking it in. So now that we don't even need the rebreathing part, I'm taking my tube from my scavenging system. It is placed directly to the bag, which it has a shut-off valve if I need to give a patient a breath. The valve is just turned on and off. So that way, now whenever the animal exhales its gas and oxygen, it simply goes to the reservoir bag and it just exits into the scavenging system. Okay, so going through the system, I failed to mention my manometer and my pop-off valve and my pop-off occlusion valve here. So the point of this is when the animal's breathing and things are working properly, it should stay between a 0 and a 2 about. If I see that, it's getting up to maybe 5 centimeters or more, then I know that there's pressure building, there's a problem in the system somewhere. Either there's a blockage or something's not hooked up correctly, so that would just bring to my attention. The other part of the manometer is if I have an animal that might need to have a good breath of air. So that with my pop-off valve, I've got this button. So how our machine works is, you hold the button down, it cuts off any air escaping to the scavenging system. It allows my bag to fill up, so that way once it gets filled, I can give gentle pressure and watch my manometer to know how much pressure or air that I'm able to give to the animal. So I know that, like, I don't want to go over about 20 pounds or the 20 centimeters of pressure for a small animal, and if we did large animal, it would be no more than 40 to 50. So those is where I failed to mention. And then the third and final part of anesthesia is the induction chambers. It's simply a box where your gases and oxygen is coming into a tank-like container. It's used for maybe feral animals that you cannot touch, small animals that just, you know, are stressed out if you put a mask on them or whatever. You want to just put them in their little chamber, and it anesthetizes them, and that way you're able to handle them and do what procedure you need to once they are anesthetized. Okay, checking our system for any leaks. I'm going to occlude the patient end of my tube. I've got to close my pop-off valve. It's completely screwed down, and this completely closes it. And then I'm going to do the oxygen flush. Oh. Trying to get my pressure up to 40 pounds.
You did.
It's holding really good. No leaks. So I'm going to let go of, open up my pop-off valve. Goes back to normal. That shows me that there were no leaks in the system. My tubing, all the way, it's on good, all the way to my scavenging system. It's all secure and on there. I don't see any damage in my hose or anything. So once I have realized that it is holding its pressure, there's no leaks, I'm going to completely open my pop-off valve, and that's how we check for any leaks. Okay, for all of our monitoring equipment here, I'm going to hook her up. We have a lingual, it's the pulse oximeter, I can't say it, pulsometer. This monitors the amount of hemoglobin, the oxygen that is going through her bloodstream while she's hooked to anesthetic. This can actually be placed on her tongue. It's one of the best places for this one. It can go on a tongue, it can go in on her ear, anywhere that it's going to pick up on the veins pretty easy. So I'm going to hook that to her tongue. Let it start getting some reading for me. While that's picking up ECG. We have this that monitors her ECG. It's showing us kind of what her heart is doing while she's under anesthesia, the beats, the rhythm, whether it's normal or not. So these are labeled for which leg and arm they need to go on. Then I need to add alcohol to make the contact work. Okay. While those are picking up, we have a probe to take her temperature while she's under. That is going to go into her rectum. So that'll be constantly monitoring her temperature, make sure we're not getting too cold while we're under anesthesia. Blood pressure monitor. I'm applying this to her leg. It tells me which way it goes on. Now this is a monitor that'll continue going the whole time. It'll just continue taking her blood pressure while she's under anesthesia. So I've got my cuff on there. I'm going to get it started. So these are already showing me. I see her temperature is at 99.3 so far as she's going down. My SPO, my pulse oximeter, is showing that she's got 99% oxygenation at the moment. It also shows me her heart rate, which matches her heart rate on her ECG. And then my blood pressure is taking its reading as we speak. So that's part of our patient monitoring that we have here. Gastric intubation. Here is a gastric tube. I'm going to measure from his last rib to the tip of his nose. That's about as far as I want the tube to go down. I'm going to take a piece of tape and mark the tube so that I know I've made it to the length that I wanted it to go. So the point of a gastric tube is to remove gases, any excess fluid, or to be able to give the dog medicines through to his stomach. I've made it all the way down. So like I said, this is to remove any air or gases in his stomach, to be able to give him charcoal if he ingested something that he shouldn't have, and able to lavage his stomach, with fluid, just to kind of clean things out. Now to be able to remove it, I want to kink off the hose, just like you would a water hose, and pull it out very slowly. That way it holds everything in the tube that might be nasty stuff. We don't want it to come out to his esophagus or to his mouth, in the indication that he wasn't tubed. He could get it down into his lungs. So that's how you would do a gastric intubation. This is my preceptor. This is Dr. Zamzo. She is the owner of this business here, so she's been helping me through my videos and my studying all this time. So you'll be seeing her in some of these videos coming up on surgery and other things. Okay, to put in a cephalic catheter, I've already shaved all the way around the leg. He was a little spooky, so we just shaved it off of camera. So I'm going to take some surgical scrub. It's already on this gauze, and we're just going to scrub the area where the catheter is going to be advanced into his leg. Okay. I'm going to take some alcohol, clean off my scrub. Now the vein is already occluded, so I can see it. I'm going to take my catheter. I'm going to use my thumb to keep the vein there in place. I can see that I'm in the vein. There's the blood coming out. I'm going to go ahead and advance the catheter. I'm going to take my male adapter plug. Now that it's taped in, I've got a flush syringe here to check to see if I have a proper placement of the catheter. It's just saline in here. I'll know whether it's in place because either it'll bubble up if I'm not in place. I'll be able to feel it going through the vein. And then after proper placement of it, I'm just going to do one last secure taping. I know it's that secure. Just extra to make sure that the catheter stays in place, not too tight.
We're okay, but
You're all right.
we're all done now.
And that's placement of a cephalic catheter. Okay, we're doing a saphenous catheter, which is in the rear leg. It's already shaped all the way around. I'm just going to scrub the area where the catheter is going to go in. Just trying to get any dirt or anything off of that area, so no contaminants are going into his vein. Give it a good little scrub. And then I'm going to rinse it off with some alcohol. Just clean the rest of his leg. Okay. Now the vein is already occluded. So now I'm going to take my catheter. I can see my vein. I'm going to use my thumb to hold it into place. I want to advance the catheter on into the vein. I'm taking my male adapter plug and I'm putting it on the end of the catheter. Then I'm going to take my tape and secure it into place. Try to take care to not pull out my catheter. And I'm going to take my flush syringe just to verify that I have the catheter in place. This will let me know whether I do by I either see fluid bubbling up, in the skin because I'm not in the vein, it's just coming out, or it'll just flush easily through, showing that I'm in the vein. And then a final secure of the catheter would just be like a layer of vet wrap. It's just another protective layer holding it into place. And that's how you put in a saphenous catheter. Okay, so doing induction of anesthesia for this dog here. The first drug that we're going to use is atropine. This drug is a subcutaneous injection, and it is used to keep the heart rate from slowing down while under anesthesia. So we're going to give our atropine. subcutaneously. That's our first step. And then we're going to use two drugs, xylazine and ketamine. These are both anesthetic. We're using these to get the dog to a anesthetic plane to where we're able to put in a trach tube for her. These are both given intramuscular. So I'm going to her rear leg here. I'm going to pull back to make sure I haven't hit a vein or any, no blood. And go ahead and get that one.
Girl.
That's a good girl.
Sweet girl.
And here's my ketamine. It's my second injection. Same thing. It's going to go in her muscle also.
That's a sweet girl. That's a sweet girl.
Full and black. No
Sweet
blood.
girl.
So I'm going to go ahead and give it.
It's a sweet girl. I know. That's a little thing.
So that's the first process of getting her ready to go under anesthesia, and then we can put her on isoflurane if needed, and we can get our trach tube down once she's asleep. Okay, to put in a trach tube, first thing I'm going to do is I'm going to check my trach tube for leaks here. I've already got my syringe to add air to check to make sure that there's no problems with my trach tube. I'm going to add. I've already met some resistance. I can feel that it's taut there. I can see my cuff blown up. Not touching the tube itself, it's still in its package. I am showing that there's there's no air leaving my trach tube. So I know that it's okay. So now I'm going to release the air. Inflated or deflated, excuse me. So now, based on the dog's weight and size, we've already picked a tube for her. It is a size 5 trach tube. She is a 14-pound dog. I've already got it marked off because we've predetermined where it needs to go. We've measured it visually this way. It goes to her thoracic inlet. So I know that I've gotten the correct size tube for her. So now, to place the tube, got my laryngoscope. The light is helping me see. I can see the opening to her trachea. I can see where her epiglottis is. So now I'm going to take my trach tube. I'm going to advance it past the epiglottis. I can feel it going down her trachea. And I'm to my predetermined spot. So now I'm going to take my gauze and secure it in place by tying it behind her canine teeth. I can already see the fogging coming through the tube, so that's one indication that I have it in the correct spot. Now that it's there, I'm going to inflate my cuff again. Not too much. I can see it blowing up. I can feel resistance on my syringe. So I know that now my cuff is inflated. I see the steam coming out. So I know that my trach is my trach tube is in the correct place. Now that my patient is hooked up and all under anesthesia, I'm going to apply lube to her eyes to keep debris out for one and keep her eyes, she's not blinking to make her tears or anything. So the eye lube is applied to both eyes, and that's going to protect her eyes during her dental. Okay, to palpate his bladder, I'm going to use both hands. This is a little bit of a bigger dog. And the point of doing this and expressing his bladder before he goes into surgery is that I don't want him urinating on himself during surgery, contaminating the field. So I'm feeling for his bladder. Feel it there. Starting to express some urine. And I would do this until I could feel that his bladder was completely emptied. So like I said, the point of doing this is to get rid of all the urine that he may have built up before he goes into surgery, and then we can scrub, and then he can go to surgery in a sterile field. Okay, to perform a clip and a scrub on this kitty that's going to be spayed, I'm using a 40 clipper blade. Got holding there. I'm laying clippers flat against the skin. Try to keep my surgical nice and square. I'm gonna get all the hair off the side. I'm going against the hair just to start out. And then I'm going to go back and get it as close as possible, going against the hair. I was going with the hair before, excuse me. Once that's been done, I can take a vacuum and get rid of all this excess hair. Okay. And I can just kind of look over and see that I'm not missing anything. No hair is going to be in my surgical site. So now I'm ready to scrub. So I'm going to start my scrub right at the incision line. And per recommendations of the manufacturer of the scrub that we're using, it's got to have about a minute of contact time. This just takes a minute. Scrub, scrub. Then about when my minute is up, I'm going to work away from my surgery site, not touching it again. And about the time I reach the hair, I can get rid of the scrub. I'm going to take, it's pre-soaked in alcohol. I'm going to do the same thing, start at my surgery site. I'm not going back over it, I'm working my way away from it. And that's first scrub. This is scrub number 2. We're going to do the same thing. Start at my surgery site, or the incision site. And another indicator by the time I'm done whether my site is clean or not, when I use my gauze pad with the alcohol, it'll come out clean. There won't be any kind of residue, no kind of hair, anything on it to show that she still needs maybe another scrub. Again, I'm going to work my way away. Alcohol again. And this This will be my third and final scrub before we move her to the surgery table. Moving away from my incision. Alcohol. There's nothing but scrub on there, so I know that my pre-surgical scrub is complete. Okay, to properly move her to the table where we're going to work together so nothing touches where we have scrubbed. It's going to help hold things in place while I tie her. Around this first leg. Do a half hitch. I'm going to do a back leg. Move on. This leg. Now, she is secure, tied into the table. So now we'll get ready to set up to do our final surgical scrub. Now that she is secure on the table, I've got sterile gloves on. I've got sterile gauze in with my scrub solution and alcohol. We already poured it onto the gauze pad. You pour out a little bit out of the container to make sure there's no contaminants from the lid of the scrub, and then just pour the rest on there. So my final scrub, I'm going to grab with my non-scrubbing hand, my dirty hand, and then I'm going to use my clean hand to perform the final scrub. Okay. Okay. working my way away from the incision site. Want to just go to that. Grab it with the dirty hand and alcohol. And if there's a little scrub left, I'm going to do it one more time with alcohol. And that is her final scrub before surgery. Okay, we are in a canine neuter right now. Dr. Zanzo is doing the neutering. I'm just staying on the end of the table. I'm not going to move. I'm just going to be here to do my anesthesia form, monitoring the dog while he's under anesthesia. So one of the things that I need while he's under is an esophageal stethoscope. That way that I'm out of her sterile field, I'm able to listen to the dog's heart rate and keep up with it that way, along with my monitoring device, but I like to be able to hear it to know that it's true. So I take this stethoscope and I just guide along his intubation tube, and I just advance the stethoscope till I can hear his heart rate the best. I'm going to adjust it where I hear it the loudest, which is there. So I'm able to listen to his heart without touching anything but his mouth. I can count his beats and keep my record of it. So, to do it anesthetic form, all I'm doing is taking my parameters. I have everything, who the animal is, how much did he weigh, his anesthetic, form of anesthetic that we used on him, what his oxygen rate is, what anesthetic we're using, which is isoflurane. So this chart is just allowing me throughout surgeries and throughout the surgery and throughout the time of the surgery, from the beginning to the end, I'm going to write things down about every 5 to 10 minutes. I'm going to take my pressures. So I'm just checking on his pulse. That's listening and taking his pulse, and then I'll make my mark on my chart where he's at on that time. And the same with respiration. I'm not going to touch him, but I can watch my bag, his breathing, count my breaths, make my mark. The only thing I'm really going to kind of take from the monitor is the blood pressure. This is also recorded on here. That way that I'm not touching anything to take the blood pressure. It's taking it for me. And his SpO2, his blood oxygen saturation in his blood. It also tells me on the meter without me having to touch him. So this is just an operative record, a paper record, along with what I'm seeing and what I'm hearing, to know that our patient is doing the best while he's under anesthesia. So if we see something that's going downward or upward, we can make adjustments to things while he is under anesthesia. So that is part of the anesthetic record, and then when he's all done, this can go into his patient file for permanent record of how he did on this day while he was under anesthesia. Okay, so if this kitty here or any animal was to go into cardiopulmonary or respiratory arrest, the steps for CPR are basically the same, just depending on the size of the animal. So a small dog or cat, I would be able to do this one-handed by grabbing him on his chest and doing my chest compressions. Now, if I had a medium to large dog, I would want to use both hands and to do my chest compressions. So for our small ones, we're going to be doing about 120 to 130 compressions per minute, while someone is hopefully on the other end. If not, I can be by myself doing it using an ambu bag. This will go over his mouth, his whole nose and mouth, to where I'd be able to give him anywhere from 8 to 12 breaths per minute while chest compressions are still going on. So the ambu bag is made to be given just pure room air to be able to, in an emergency situation, get oxygen to the animal as quickly as possible, while we're trying to get to a situation where we can possibly tube him That way we can hook him up to straight oxygen. Or if he's already anesthetized, say we're in surgery and he goes into one of these arrests, we would just be able to hook this up to an oxygen source to where he's getting actual oxygen to his lungs while doing our CPR. So that's kind of the basics of doing CPR and using an ambu bag and what it's for. Okay, to do a surgical hand scrub, you take your pick, you got to clean out from under each of your fingernails. Get as much dirt, debris, anything that might be there. Do both sides. That one there. Okay, after I've cleaned out my fingernails, I'm going to take my sponge. It's already got the scrub solution in it. It's got a scrub pad on this side. I'm going to get it wet. And to do a surgical scrub, each hand and finger has to be scrubbed. I'm going to use the scrub side. Every finger has to be done, 10 strokes. Moving all the way around, 10 strokes. So I'm going to do that to every single finger, front, back, side, front and back of my hand, and then I'm going to work my way all the way up to my elbows. I'm going to do this on each hand. So I'm going to go ahead and do this. It's going to take a while. It's going to be about 10 minutes total, and then we'll rinse and move on. Okay, now that I've performed my scrub, I am going to rinse. And I got to start from the tips of my finger and just let the scrub run down all the way up to my elbow. Careful not to touch anything. Okay, I'm going to move over to where my gown is at and my towel. I'm going to let it fall open. This is a sterile towel. Use it to dry my hands and my arms. Careful to not let it touch anything that hasn't been scrubbed yet. Okay. Then I'm going to take my gown. It's come out of my the sterile pack. I'm going to pick it up. And I'm going to let it fall. I'm careful not to let it touch anything else in the room. I'm simply touching the inside of it. All of my outside. Okay, so now to take my gloves, I'm not taking my hands out of my sleeves. I'm going to grab everything with my sleeves. This is my left hand. I'm grabbing the cuff of the glove with both hands. I'm going to work it around. Once it's getting over, I can get my fingers in. Before I grab anything else, I'm going to work with my other hand first. This is difficult, if you cannot tell. pull down the cuff with the sleeve to help get my fingers in it the rest of the way. Same here, the cuff and the sleeves. And there's gowning and closed, gloved, gowning up. Okay, to organize the surgery table or tray, this is all sterile. I've taken off, or the nurse has taken off the outside. So I'm going to open up the pack here. I'm going to take my gauze, set them up here. Got the scissors, my forceps, and my scalpel blade. Kind of in order of how Dr. Zamzo would like her surgery to go. I'm going to set these to the side, so they're just kind of in order of the way that we'll be handing her things and her using things. So that's setting up the pre-surgical table. Okay, to direct the patient, I'm taking my sterile hub towels here. Got to be careful not to go over my incision site or reach over the field. Not reaching over the incision site. Then I'm taking my towel clamps. I'm going to get the patient a little bit of skin and the towels to help hold things in place. Okay, then I'm going to take my drape. It's already got a slit in it. It's going to cover the whole patient. Work it to where my slit and then a final. Securing it in place. How you drape a patient for surgery. Okay, to help Dr. Zamzo out, to block any excess bleeding, it's simply the sterile gauze, just getting rid of any excess bleeding. Like they say, happy tissue. This is sterile bowl, sterile gauze, getting it wet. Not going to touch any of the incision. It's simply wanting to keep the tissue moist, keep any wetness so the air is not drying it out during any of these procedures. Okay, properly loading a scalpel blade onto the handle. I've got them clamped in here. Make sure they're properly in place. And then I'm going to hand them safely to Dr. Zamzo. That way she can use them to cut. And then any of my hinged forceps that she may need throughout the procedure, just going to properly hand them to her like this. All she has to do is grab them, and then she is ready to use them. And the thumb forceps. The thumb forceps, the same thing. Just need it to be able to be handed to her to where she can use them as she needs them. Okay, staying sterile during a surgical procedure. You know, this is my sterile field. I'm never going to let my hands drop below my waist. I'm always going to be facing the surgery site. If I'm not needed, I'm going to keep my hands clamped here until I'm needed. If I ever need to grab something off the instrument thing for tray for Dr. Zamzo, I'm going to make my way around, constantly facing the surgery table. Just proper, what am I trying to say? Surgical asepsis is the best way to go about it. If for some reason I get my glove nicked, or Dr. Zamzo does, we have to unglove, ungown, and redo it all over again, unless I have someone to help re-glove. But we would have to re-scrub, re-glove up, re-gown up, just kind of start all over. The same with if we draw for an instrument. Here in our clinic, we have some backups. So if one was to be dropped on the ground, not going to do anything. We're just going to leave it there. We're going to get a sterile one opened of that same instrument to make sure we can just continue on with surgery and that the animal is not under longer than they need to be. So these are some of the techniques for staying sterile during a surgery. Okay, so I am not completely surgically scrubbed in, but I'm here participating in a feline neuter. I'm going to be the anesthetist and watch all my parameters while Dr. Zamzo does the surgery for this feline neuter. We're scrubbed up and we are in a canine spay. Right now I'm prepped and ready to help Dr. Zamzo with anything that she might need during this spay process. Okay, post-surgical cleanup. I'm going to start with my instruments. These are the instruments that were used in surgery. There's my scalpel blade. We're going to dispose of it properly. Come to the sink. So all of our sharps go in our sharp containers. We have them all over the clinic, but this is just one that we use for our surgical. I'm going to place all of my instruments unhinged, open, let them soak. Distilled water, cold distilled water. This is a cleaner and a lubricant made specially for surgical instruments. So I'm just going to pump it right in there. It doesn't take much. So while all of this is soaking, I'll just let it soak while I'm going to finish the surgery room. So cleaning the surgery room includes, we're going to get rid of any linen. This will need to go to laundry to be washed. That'll go out of the room. Disposing of any trash that we may have used during surgery. Here are extra instruments that I'll get cleaned. So these will all be cleaned and packed away. The handle that goes on the surgery light. This will be wrapped back up into a package and disinfected in the autoclave. Our light will need to be cleaned. The surgery table itself will need to be cleaned and disinfected. There's a tray in here that we'll take out and we'll clean and disinfect it too. We use a solution, just one of the solutions we use. It's called Kenasol and then Kenasol, and we mix it with water, whatever the manufacturer says per gallon or whatever. I'll use cloths to clean everything down. I'll be cleaning you don't need to see me cleaning the whole room, but I'll get it done. The whole cart itself will need to be wiped down once I dispose of all this. all of my anesthetic equipment. Everything will need to be dusted and wiped down, anything that may have been touched during surgery, and then it just stays into the room. Our table that we use for our gowns and gloving up, those will go and get cleaned up also. Anything else, stools in the room, the whole base and that part of the table will be wiped down, and then I'll end up doing the floor. So we'll sweep and we'll mop, and anything else that I see, the surgical scrub sink, it'll need to be cleaned. You see the soap and stuff on there. So everything in the room after every surgery of the day gets cleaned, disinfected, and wiped down. After I'm done doing that, I'll go back to my surgery, to my instruments. After they've soaked, I take a nice toothbrush. I will scrub all my pieces, all of the hinges. Everything will be nicely scrubbed, all of them. Then I'll rinse them in distilled water. And then they're going to lay out on a cloth or a lint-free cloth to air dry until and then I'll come back and check everything. Once they're dry, then they'll be ready to be packed and to be used and sterilized again. Okay, to pack a surgical pack, all my instruments are cleaned. I've got them all paired together. So these are all of my forceps. None of them are latched. They don't need to be latched going into the pack. I've got my scissors here. Also, they're just going in open. Got my needle holders. Tissue clamps and my scalpel blade. Then I have my drape. I've already started to do the accordion fold on it, so I'm just going to finish that off. Just to show that that's how it's going to go into the pack also. So that goes into the pack. I've got for our clinic, our recommended number of gauze pads are already counted out. And there's a reason behind counting the gauze, so we make sure nothing is ever left behind anywhere. So that also goes into the pack. Then I'm going to put the lid. Now we have 2 layers. I'm going to first wrap it with a pup towel. All my corners are up. The weight can only be grabbed just by 2 fingers. Okay, and then we're going to move it over to our final wrap. Now this wrap is large because I want it large enough when it's open that it covers the table, the instrument table that it's sitting on. Now I'm wanting all my corners where I can grab them when I'm trying to open the pack when we're getting ready to do surgery again. So I'm folding it. All I have to do is grab that. And with this, all I have to do is grab that. I will not touch any of the interior stuff that will be sterilized on this pack. Same with this, it's going to be tucked in. To where all I have to do is grab the outer ledge to where I can undo everything. Then we wrap it. making it to where I can simply open the tape by it being like that. I'm going to label it with my initials. We have different packs in this clinic. This is our pack number 2, and then today's date. And then the final part of this is our sterilization tape. On the end of it. Now, as you see, this tape is white. There's got white lines on it. This tape is going to tell me, after it runs through the autoclave, whether it got sterilized or not. So, we're going to take it to the autoclave. Okay, getting my surgical gown ready to wrap. Folding it is important of how it's folded. I'm wanting all of my, the outside of the gown to be folded to the inside. That side. Okay. So the gown is inside out. I'll lay it flat on the table. And I'm going to accordion fold it so it just kind of falls open. That way I can just grab it whenever I'm ready and just let it fall open, and it'll be still as sterile as possible. And then I'm going to take our hub towel. This will be used to dry my hands after you do your scrubbing. It's also going to be folded accordion style. That way I can just grab a corner of it and let it come open and not touching much of anything. And we'll put it on top of my gown. Then I'm taking my straight material. Again, folding it just like you would do a surgery pack. When you have your little tags or spots sticking out to grab, with one finger, not tucking everything in. Thing is laid where I can just grab a piece and open it without getting to any of the inside sterile stuff. Trying to make it tight as possible so it'll fit in our autoclave. That's another problem. Grab my little tab and open it, and then I'm taking my sterilization tape so that way I'll know after it's been autoclaved whether it got sterilized or not. Putting that on there. Then I'm marking this that this is a gown. Putting my initials and today's date so that we know the shelf life of the sterilized gown. So that's wrapping a gown. Okay, there are many different types of autoclaves. Some are run off of gas, some are cold sterilizations, some are steam. This one that we use is a steam autoclave. It is run by heat and distilled water. So there's components in it. So this thing has to be cleaned on a monthly basis. All the water needs to be drained out of it. We add fresh distilled water to it. We run the speed clean through the machine, and then we empty the water out again, and then all of my trays and components, everything comes out, gets wiped down and cleaned, and then again add fresh distilled water to it again. So moving on to, this is how we pack the autoclave. My wrap package goes on in there. It sits right on the tray in there. I make sure that I have plenty of water in the chamber to make the steam. So then we lock it into place. Okay, so this one, this autoclave, the recommendations is that it runs at 250 degrees for about 25 minutes. So I'm gonna get the timer going. So it takes about 6 to 7 minutes to get up to that temperature, and then I will turn the heat down, and then I'll readjust my time to make sure that it runs at 250 degrees for 25 minutes. So whenever it is done, I'm gonna let it run its cycle, and then we'll pull it out and make sure that my indicator strip tells us that it got sterilized. I couldn't think of the word. Sterilized. That's it. Thank you. I forgot to mention yesterday, so I'm gonna mention it real quick. That this autoclave runs at 15 psi, pound per pressure, at 250 degrees for 30 minutes. So that's the pressure that it runs at. So now that it's done and it's pulled down, we're going to take our pack out. And I can see my indicator tape now has the black lines. This shows to me that it was properly sterilized. Okay, removing stitches. First thing we want to do is look at the incision itself with the stitches still in there. I know that this cat was spayed about 10 days ago, so we wait about 10 to 14 days to look to remove stitches. So I'm looking for any redness or swelling or drainage from my womb, any little openings that would indicate that I would want to leave the stitches. Hers look really well. The skin has healed together. There is no opening. These stitches are ready to come out. So I am going to grab the knot in. I'm going to cut right under it and pull them out. Okay, baby. Hang in there, Lily. Go under it, snip, and pull it out. So that's how you remove stitches from a womb.